welcome everybody. It is my pleasure to be introducing to you the talk from Leo Cancer Care today on the more human way to treat cancer. The speakers for today will be myself, Stephen Towe, CEO of Leo Cancer Care, Mackie, Chairman of Leo Cancer Care, and Niek, Schreuder, the President of Proton Therapy for Leo Cancer Care. So let's just start this talk by really looking at a couple of the unquestioned principles that we have in radiation therapy. So we treat our patients today with many different types of radiation, all the way through from carbon to photons. And we accelerate and produce that radiation with lots of different types of accelerators, from linacs through to synchrotrons. And we also treat many different parts of the human body, many different indications, with lots of machines that look very, very different. But there are really two core ideas at the center of radiation therapy, which we don't question very often. The first of these principles, the idea that patients are treated lying down. And at Leo Cancer Care, we have questioned that and asked ourselves, what happens if we actually treat patients in the upright orientation? And Rock's going to talk a lot more on this around the clinical benefits of treating patients upright. And the second core idea, what happens if we don't just treat with gantries and actually we keep our radiation fixed and rotate patients instead? And Niek is going to talk a lot more in the second half of the talk about the economic benefits that we can get from doing that. So really, these two core ideas in radiation therapy exist and are not questioned, because there is very much an idea of we've always done it this way. We've always treated patients in the same way. But we sat and looked at various different examples in technology where we could have had exactly the same attitude. But thankfully, all of these things that you see on the screen now, we found a better way. We found the smartphone. So what is the innovation that we have here at Leo Cancer Care? Well, it's really a tale of two halves. First off, we have a patient positioning system that treats patients in the upright orientation and is specifically optimized for treating head and neck, breast and lung, and prostate. But what's important when looking at treating patients in the upright orientation is that we can also image in the upright orientation. And this is really the second half of our innovation. A dual energy CT system that is capable of imaging patients for all of those indications as well. We're first bringing this innovation into proton therapy. So we're able to bring diagnostic quality dual energy CT to the isocenter to improve our patient positioning accuracy. And we're partnering that with a very flexible upright patient positioning system that can rotate incredibly easily in front of the fixed beam, so that we can deliver multi-beam treatments in an instant. And we're not just stopping at proton therapy. The benefits of upright patient positioning apply to protons and photons alike. So we're taking our patient positioning system, but that for the first time truly optimizes patient posture based on indication, and then takes the patient in their optimized posture and with a fully robotic, state-of-the-art 6-degree of freedom base, moves that patient with respect to the fixed photon beam. We're taking all of that patient positioning innovation and technology and partnering that with a fixed beam 6 MV linac and fully integrated KV imaging system. By rotating the patient in that treatment and imaging volume, we achieve the same state-of-the-art photon treatment delivery, but at a fraction of the cost and with all of the benefits of upright patient positioning. So now I'm going to hand over to Mackie, who's going to talk through the clinical benefits of upright patient positioning.
Thank you, Stephen. Turns out upright radiotherapy is often better medicine. So for example, in the lung, the diaphragm pulls down the lung so that the lung is more inflated. This means that for a given tidal volume, the amount of motion is reduced. And for proton beams, it means that there's less lung in the field, and so that there is less normal tissue to avoid. In the liver, you'll see that there's a situation of less systematic liver drift, and I'll explain this in some detail. And in the bladder, there's less issue with bladder filling. Perhaps very important is the psychological and physiological comfort of the patient. And in fact, many patients now in radiotherapy in the supine position find it difficult to swallow, and being up, swallowing is much easier. And this is really true for gastric reflux as well. And so the combination of better medicine and better patient comfort, we think, is extremely important. An important new study from the group of Tony Lomax at the Paul Scherrer Institute in Switzerland has shown that the liver actually, in the transition from upright to supine, which is done conventionally in radiation therapy, has a slow drift. And this drift takes many tens of minutes to stabilize. This means that conventional radiotherapy of the liver is likely often missing the tumor. And in fact, upright radiation therapy, there's no transition from upright to supine, but the patient stays upright, that this should not happen. This slide shows that there's a marked difference in the shape and position of the bladder for pelvic radiation therapy, specifically shown here for prostate radiation therapy. So on the left is a full bladder in the supine position from a volunteer, and then the volunteer was re-scanned here on an MR scan in the upright position. And you see that in the upright position, the bladder flattens out and does two things. One is that it prevents the small bowel from getting into the field. And secondly, on this image, it shows that in full bladder, as compared to empty bladder, there is very little motion of the prostate. So here you see the full bladder, and here you see in dotted lines the empty bladder, and there's very little change in position as compared to conventional prostate radiation therapy in the supine position, where small changes in bladder filling mean relatively large changes in the position of the prostate. We did a study of a prototype upright positioning system with our partners at the University of Surrey in conjunction with the National Physical Laboratory in the UK and CIVCO. And this is the motion capture system where we showed that it's perfectly reasonable to set up a patient in the upright position and keep them stable. And this really corroborated the findings of the work at MD Anderson. One of the things that we found out is that in breast radiation therapy, the breast is falling forward, and the arms don't have to be above the head, but can be put in a more comfortable position, just holding the fingers behind the head at 90 degrees. So what about for non-ambulatory patients? Well, paraplegic patients who are coming into the clinic in a wheelchair can be easily transitioned into the seated position, as they would normally do many times a day in their current life. In terms of quadriplegic patients, they have already using systems that allow them to stand up, and they can be transitioned relatively easy into the perched position. And what's key in both of these is the knee stop that prevents the patients from sliding forward. And now I'll hand it over to Niek Schreuder, who will talk about the economic and throughput advantages of upright radiotherapy.
Thank you, Stephen, for introducing the LEO technologies to our listeners, and Rock for discussing the clinical benefits. So when it comes to cost saving or cost efficiencies, or how can upright treatments save us money, It's good to start with a picture looking at the typical size of two room temperature gantries. These are generic gantries, not by anybody's specific design. And it also means we can use any accelerator to feed the beam in. And if you can see on the picture on the right, if you just replace one gantry with an upright system, then you can see the enormous savings in size. If we go to the next slide, we can look at the shielded volume required. And if you look at a typical gantry, and these are just generic numbers, in my research, I found some gantries that need much, much larger space. But there's, of course, also some of the more modern gantries that needs less space. But typically, we need 56,000 square feet of a volume to be shielded to build the gantry system. If you do the same comparison with the upright treatment room, then that number comes down to 3,200 square feet, cubic feet. And the ratio is about 17.5 times less shielded volume if you go in the upright fashion. This upright treatment room is the inside of the room, of course, and it's still fairly sizable. We can see it fits in something slightly smaller than a typical LINAC room. Now, this is now just to see how we are planning to use this current configuration. And we can see on the left is we still do not say that do away with gantry systems. We still think the gantry system would be your more specialty machine that can be used for young patients that need anesthesia or leg sarcomas extremities, or also adults that, for example, cannot sit down. But as you will see in the next couple of slides, we believe that the upright room would become the workhorse machine because we can install more of them and we can install them in existing LINAC rooms. And these will be used for those specific areas that is really going to be well treated in the upright position from a patient comfort perspective. And in that list is the head and neck patients, lung, liver, prostate, and then certainly the patients who cannot lie down. We all know that patient comfort is sometimes heavily compromised when the patient has pulmonary problems or neck pain or claustrophobia problems. So we can see this is in the proton therapy or the particle therapy space, a huge cost reduction when it comes down to just the physical shielded volume. But as you probably also know, and as we know, we're also building a linear accelerator that to operate in the upright position. And here on the left, we can see a picture of our Ruby device, which will be a 6 MV flattening filter-free IMRT machine. By rotating the patient and then using cone beam CT for volumetric imaging, we know that these machines now can be very, very effective in terms of shielding the machine. And as we can see on the picture on the right, we believe 2 of these machines will now be able to fit in the space from the existing LINAC. If you look at the typical flow diagram of a radiation therapy process, then we know there's 2 parallel processes. The one is about dealing with positioning the patient and make the patient comfortable, make sure the patient is in position and ready to treat. And simultaneous to that, there's a process that controlling the beam to be delivered to the patient. And this diagram is generic to any type of radiation therapy, external beam modality we use to treat. But we find that when it comes to patient positioning, although 95% of the time to treat a patient is spent here, there is a really lack of standardization between different modalities. And we often need modality-specific technologies to treat these patients. And since we as a company is now moving into the field of upright therapy for both particles and photons and eventually electrons if needed, we believe that we'll be able to standardize this specific arm of the treatment process. So whether you treat on a photon machine or a proton machine, the immobilization devices and the methods of measuring the patient position and comfort is going to be the same. Right, so when it comes to efficiency and workflow improvements, I want to point out a couple of aspects here. The first thing that the upright scenario would bring to us is much easier access for the patient to isocenter. So as we can see from the picture there, there's plenty of free space and the patient can literally just walk in and sit in the machine without having to crawl in and maneuver in around crowded spaces. The second aspect is, as you can see here, is a rendering of how the system would look like in a typical fixed beam. It could be a photon beam coming out of the wall or a particle beam. And we can see there's plenty of room to install new imaging devices for image guidance. So dual energy CT at isocenter, proton radiography, proton tomography, and many other in vivo technologies that exist today, but hard to install in gantry systems. The third one is that having the dual energy CT at isocenter will definitely allow us to treat with more accuracy, reduce the margins, and also allow us to do progressive plan adaptation, which will allow us to shorten the wait time for patients. If we bear all these things in mind, and then we then look at a typical time saving, if I make a comparison of a single field treatment, regardless of the modality, all I'm comparing here is whether you treat in the upright position or supine position. We can see there's about 3 places where we can make significant savings. And the first one is where you make the patient comfortable to start the treatment. And the second one is we have to rely heavily on optical tracking to make sure our patient position is in the right posture. And the last one would be to get the patient out of the treatment position. We can spend a lot of time on this, but I think it's pretty obvious that as you just walk in and sit on the treatment device, basically step 1 of any patient positioning process is actually the final step for the patient positioning, patient for treatment, and the reverse is true. Step 1 of getting the patient out of the treatment room is the last step as you have the patient sit up and walk out. So if I look at this comparison, then it's very obvious to see that we can save up to 6.5 minutes just for one single beam. That makes us believe that our efficiencies will be much, much higher. So we come to wrapping up what we mean with how this can save cost. And if you look at cost, the capital cost, the equipment cost, the building cost, we believe that if we can reduce the size of the equipment and the buildings, we can make radiation therapy and more so particle therapy significantly more cost effective. The workflow improvements that we touched on will also have a huge impact on the bottom line of the operations. And we believe that this will definitely have a significant impact. As my previous speakers in this audience and this session was talking about the clinical advantages, we believe combining the clinical advantages with cost effectiveness will make this a very viable option for the future. Thank you everybody for listening to this presentation. Why don't you come visit our virtual booth at the Astro show and also get more information on our website as can be seen on the screen there. Thank you very much.